Assalamu alaikum. This presentation is on a group of disorders that affect the vocal process of the arytenoid cartilage, causing microtrauma and granulation tissue formation. These disorders have some common features between them, including the pathogenesis and some of the clinical picture, but it's important to differentiate between these subtypes in order to refine the management selection. The three common members of this group of granulomas over the vocal process of the arytenoids are granulomas following voice misuse or abuse causing phonotrauma, and granulomas following intubation, and granulomas following laryngopharyngeal reflux. There are also two less common disorders that we're going to touch on: the osteosclerosis of the arytenoid cartilage and the arytenoid cartilage rotation or malrotation in the case of vocal fold paralysis or vocal fold bowing. Several names or terms were used to describe the adenoid granulomas, including vocal process granuloma, contact ulcer, contact granuloma, intubation granuloma, peptic granuloma, and contact pachydermia. Many clinicians would lump the most common three, the contact granuloma, the intubation granuloma, and the peptic granuloma, into one big group, the vocal process granulomas. Differentiation between these subtypes is important and can be helpful in the selection of the treatment and also to avoid recurrences. This group of disorders have a common pathogenesis. The key event is injury to the very thin mucoperiosteal layer over the vocal process of the arytenoid by a repetitive trauma or prolonged trauma. This is followed by ulceration and attempts at healing by secondary intention. And the healing is usually protracted and followed by proliferation of the granulation tissue with some epithelial hyperplasia. The injury, the mechanical trauma, can follow either intubation or from repeated impacts of the vocal process against each other during voice misuse or abuse, or during throat cleaning, coughing, or talking in a habitually low-pitched, creaky, hyperfunctional voice. This group of disorders are perhaps more appropriately termed arytenoid granulation tissues rather than granulomas. Unlike true granulomas, they don't have any giant cells. They are a rounded mass of accumulated granulation tissue over the tip of the vocal process of the arytenoid, formed basically of capillary proliferation and fibrous tissue. They are covered by hyperplastic or metaplastic epithelium and ulcerated in parts. The pathology also includes a variety of acute and chronic inflammatory cells. Here are the three major subtypes of the arytenoid granulomas: the intubation granuloma, the contact ulcer and contact granuloma, and the granuloma following laryngopharyngeal reflux. The intubation granuloma can be characterized with a clear history of laryngeal intubation, injury, or surgery. The granulation tissues are florid, exuberant granulations forming a mushroom-like structure with a narrow pedicle. The contact granuloma starts with a contact ulcer, a whitish ulcer with an intense hyperemia at the edge of the ulcer itself, and it's usually painful. The ulcerated area would start secondary intention healing with granulation tissue that can form masses with different shapes like bilobed granuloma or cup and saucer type of granuloma, The history would include voice misuse or abuse, and it's predominantly a male condition rather than the intubation granuloma, which affects females more. The third type, the granuloma following laryngopharyngeal reflux, will be characterized by diffuse congestion of the larynx and the pharynx, perhaps with some interarytenoid pachydermia and little granuloma over a small ulcerated area on the arytenoid tip. We shall now go with more details on these subtypes in the next slides. Starting with the most common arytenoid granuloma, the contact granuloma. It forms due to the forceful adduction of the arytenoid process against each other during voice misuse or abuse, or during actions like cough or throat clearing. The site of injury is always on the tip of the vocal process of the arytenoids. They don't involve the membranous part of the vocal folds. It affects men much more than females, and it is the pattern of the voicing that determines its development. Like repetitive, aggressive, emphatic articulation would usually cause this type of lesions. Some dialects, like a German dialect, would have more tendency to form the granuloma, in contrast to other languages like the Italian or the Spanish language. Contact granuloma starts with a contact ulcer. Early in its development, there will be a hyperemic area on the vocal process of the arytenoid, perhaps with some discomfort during phonation. This hyperemic area may have a whitish center due to some hyperkeratosis of the epithelium, but the rim of congestion around it is characteristic. Ultimately, there will be breakdown of this whitish center to form an ulcer with a hyperemic crater. The next phase in the development is when the central part of the lesion breaks down to form an ulcer. Here there will be pain on phonation, pain on clearing the throat or coughing. There will still be a hyperemic ring around the ulcerated area. The ulcerated area itself starts to be covered with granuloma, irregular and little amount of fibrin tissue on top of the ulcerated surface. Ultimately, this little granulation tissue would continue to grow, forming a mass-like structure that can take different forms, either bilobed granuloma or a cup and saucer type of granuloma on the tip of the vocal process. The majority of patients with contact granuloma are middle-aged men. They form the granuloma secondary to vocal hyperfunction, although we'll discuss two situations in which vocal hypofunction can also lead to a contact granuloma. Patients would notice a change in their voice or symptoms of voice fatigue. They also describe early some sensation of a tickly throat, followed by a sensation of pain on one side of the throat that radiates to the ipsilateral ear. This pain is made worse on phonation, on clearing the throat, or on coughing. Some of them would have laryngopharyngeal reflux or gastroesophageal reflux symptoms like choking episodes. Almost always the lesion is unilateral, in contrast to chronic laryngitis, in which the symptoms are diffuse and sometimes bilateral. The onset of the symptoms can be gradual, starting with a tickly throat, proceeding to pain and worsening of the voice, or it can be abrupt following some change in their circumstances, like a period of stress or travel, or after upper respiratory tract infection. Isolated inflammation or ulceration of the arytenoids can give rise to pain. It's usually unilateral, localized behind the thyroid cartilage, and the pain would sometimes radiate to the ear. This can happen in the cases of contact ulcer, contact granulomas, but it may also be described in conditions like arytenoid ankylosis or with arthritis. The voice of contact granuloma patients would be strained due to the hyperfunctional nature of their voicing, but it may also be a bit breathy because the granuloma may interfere with complete glottic closure during phonation. It would have a rough quality, and characteristically there would be a low pitch voice, sometimes a vocal fry quality. The dynamic range of the voice would be limited and the voice would be monotonous. The patient would speak in short sentences at the end of a short breath. Stroboscopy would show a longer contact phase. Laryngeal examination and arytenoid granulomas are better carried out with the use of a rigid 70 degrees or a 90 degrees telescope because they would help in showing the early subtle changes in the vocal process of the arytenoids, like some congestion or some small ulcer before the granuloma itself forms. The endoscopic features of the granuloma can be seen on laryngoscopy together with features of hyperfunctional voice like shortening of the anteroposterior dimensions of the vocal folds during phonation, and also attempts of the ventricular folds to adduct during phonation. There will also be lack of cricothyroid activity with cricothyroid membrane lock during phonation. Contact granulomas usually form with hyperfunctional voice disorders, but here are two examples of hypofunctional voice disorders that may cause contact granulomas. One is vocal fold paralysis, the other is vocal fold bowing in the elderly. In vocal fold paralysis, the arytenoid on the paralyzed side would rotate forwards and medially. It would not be on the same level with the mobile arytenoid. Some patients use to compensate for the hypofunctional voice by forceful adduction or attempts at forceful adduction. The mobile arytenoid would hit the arytenoid on the paralyzed side at a higher level because they are no longer on the same level. And the site of collision may actually be higher up in the arytenoid body of the paralyzed side, or even in the corniculate or the cuneiform cartilages of the paralyzed side. This is where the ulcer is going to form and the contact granuloma is going to form as well. And the other example is the vocal fold bowing in the elderly, and again something similar is going to happen. Some patients will try to compensate for their hypofunctional voice by forceful adduction, causing the collision of the two arytenoids, which because of the changes in the vocal folds in the elderly would be more skeletonized and more prominent, and this is going to form a contact granuloma. To treat these two conditions, the patients may require laryngoplasty or thyroplasty to close up the glottic gap during phonation, combined with arytenoid adduction procedures to correct the problem with the levels of the arytenoid. The second subtype of arytenoid granulomas is the intubation granuloma, caused by localized injury to the mucoperichondrium of the vocal process of the arytenoid from the intubation or from laryngeal trauma or surgery. In contrast to the contact granuloma, which has wide base, here the base would be very narrow. It it will be a pedunculated mushroom-like granuloma with a narrow pedicle. It's usually unilateral, but it can be bilateral as well due to the pressure of the tube on the two sides, and other lesions may form in addition to the contact granuloma, like small cysts lined by squamous epithelium, again on the tip of the arytenoid process. Intubation granulomas, in contrast to the contact granuloma subtype, affects females more than males. The smaller female larynx makes it more susceptible to injury by the pressure of the endotracheal tube, particularly if it is left for longer periods. The ulcer on the tip of the arytenoid process can be made worse with the effect of laryngopharyngeal reflux. These patients describe voice disorders in the form of dysphonia or even aphonia, but again, in contrast to the contact granuloma, they don't describe much pain or irritation in the throat. The intubation granuloma can reach a large size. They are pedunculated and are mobile and can form a ball valve that can partially obstruct the laryngeal airway during breathing. Third subtype of the arytenoid granulomas are those associated with laryngopharyngeal reflux. Laryngopharyngeal reflux can affect children or adults. It can give rise to acute symptoms, chronic symptoms, or intermittent form of laryngitis. These can cause inflammation of the arytenoid, sometimes with ulceration, with or without granuloma formation. The characteristic feature is the diffuse nature of the condition that affects most of the larynx and also the hypopharynx, can give rise to interarytenoid pachydermia and a small amount of granuloma on the arytenoid cartilage. The irritation and the inflammation of the larynx with laryngopharyngeal reflux can give rise to frequent attempts at throat clearing or cough or occasionally laryngospasm. All these can add to the injury to the vocal process of the arytenoid during repeated adduction and can give rise to a small ulcer and a small granuloma on the tip of the arytenoid process. The presenting features for this condition would be the throat irritation, a globus sensation, and frequent cough. The changes in the voice may be secondary to the presenting symptoms of throat irritation. Differential diagnosis of arytenoid granuloma include things like laryngeal papillomata, benign keratosis, or even neoplasia. The decision to take a biopsy should be considered carefully because the surgical trauma associated with the biopsy taking may actually increase the granulation formation. Biopsy taking from these lesions should be restricted only to the cases where there is doubt about neoplasia or any other sinister pathology, and in conditions in which there is a doubt about upper airway obstruction due to the size of the granuloma. A CT scan of the larynx is rarely required, but should be considered in some cases like repeated recurrences of the granuloma to look for any hidden pathology, and in cases of arytenoid asymmetry in size, which may reflect osteosclerosis or osteitis of the arytenoid cartilage. These conditions of osteosclerosis or osteitis may follow injury to the arytenoid cartilage, followed by inflammation, chronic inflammation of the cartilage that would produce chronic granulation tissue from this inflammatory process. These very rare cases would require long-term steroid and antibiotics to control the chronic inflammation. The main lines of treatment for arytenoid granulomas include things like reducing the effect of laryngeal irritants, stopping the smoking, improving vocal hygiene, treating any respiratory tract infections or allergies, and control of laryngopharyngeal reflux. Voice therapy is also a mainstay in the management of arytenoid granulomas, with raising the awareness of the condition, reducing the hyperfunctional element of the voicing, and preventing any voice misuse or abuse. There is no good evidence to support the use of antibiotics. In general, only in very selected cases where chronic inflammatory processes in the cartilage are suspected. Symptoms may improve by inhaling steroids or even systemic steroids, again in selected cases. Nebulizers can decrease the throat irritation. Surgery in the form of micro-laryngosurgery should be a last resort in the management of arytenoid granulomas. Surgery alone does not cure arytenoid granulomas, and there is a very high chance of a recurrence. But surgery is helpful in confirming the diagnosis and excluding a sinister pathology, and can also be helpful in debulking a large lesion that may threaten to compromise the airway. If surgery is chosen, then lasers usually gives a better success rate, and they also reduce the amount of bleeding from these vascular lesions. Care must be taken to avoid any thermal injury to the underlying cartilage during vaporization of the lesion. A pulsed laser, sometimes dye lasers, has been used with success, and following the removal of the granuloma, one may consider the use of local steroids or even mitomycin to help in preventing a recurrence. There is also a need to consider the use of Botox injection in the thyroarytenoid muscle, small amount like 5 to 8 units, to reduce the impact of the adduction that may help in the recurrence of the granuloma. Anti-reflux measures are essential in the management of arytenoid granulomas. There are usually 3 levels of anti-reflux treatment depending on the severity of the condition. Level 1 is just diet control and lifestyle adjustment, perhaps combined with some antacids. And level 2, there is also in addition H2 receptors antagonists. Usually with arytenoid granulomas and laryngopharyngeal reflux, these 2 levels are not very successful, and one have to proceed to level 3 with either long-term use of proton pump inhibitors or even fundoplication to prevent the reflux. The proton pump inhibitors should be given in twice daily doses and for prolonged periods like 6 months and more. By this, we come to the end on this presentation on the subtypes of arytenoid granulomas. Assalamu alaikum.